I'm going to talk in 15 minutes about management of back pain and neuropathic pain. I'm afraid I may have to rush a little bit, so you might let me at the lunch break. To start with, I'm going to start with an imaginary patient, which we see most commonly in the clinics. It's a 50-year-old gentleman, Mr. Yam, who has been complaining of low back pain, right side more than the left side, and the pain does go up to the right knee. It does not go beyond the right knee, and he vaguely remembers lifting a heavy suitcase about 3 days ago when he traveled in a plane. And on further questioning, he's been having on and off low back pain for a few weeks from now. Now, when we see such patients, these are the questions that go through our mind. First thing is it really low back pain, or could it be a referred pain from abdomen or hip or from somewhere else? And what is the somatic component of the pain? Is there any neuropathic element in the pain? And should I investigate this? It is much more likely to be simple mechanical low back ache, which is age-related change really. But again, we should know when to investigate it and when not to investigate it. And what is the initial management of such individuals? And is this patient at risk of having a chronic low back ache later? And what are the treatment options we have, and what medications would be ideal for this individual? Start with red flags. I'm sure most of you here would be aware of red flags. They were started in 1994, and they suggested that if the patient has got risk factors, we should investigate them, or we should refer the patients, because these may herald something sinister. Now, these are the diseases we are looking for, mainly vertebral fractures, vertebral metastasis, inflammatory arthritis, infections, and ARDA equina. Now, there was a recent meta-analysis in the BMJ, I think last month. It clearly showed that individual red flags are not important anymore. We should not get excited too much about individual red flags. But however, when a combination of red flags is there, it is quite important, and it might herald something sinister. Now, for example, in vertebral fracture, age above 70, female sex, and history of significant trauma, and history of steroid use, it predicted a vertebral fracture in about 90%. However, the meta-analysis clearly said that the clinical judgment was far more superior, even with the combination of red flags. Now, out of all the red flags, the history of malignancy, especially within the last 6 years, was highly significant. So it had a positive predictive value of up to 33% in identifying something sinister. And the more common red flags like old age, recent history of weight loss were not that specific anymore. So they said if the patient has got a history of malignancy with the recent onset of weight loss, that patient should be investigated immediately. So the red flags, focusing on red flags alone resulted in over-investigation. So the recommended investigations, these recommendations were taken from the app of its medicine recommendations, which are in the website of British Pain Society, and they were recommended. I think it was published about 6 months ago. So, if malignancy is suspected, routine inflammatory screening is recommended, and ESR of more than 20 is highly suggestive of something systemic ongoing. And profile. The most common vertebral secondaries are from CA, breast, prostate, multiple myeloma. So if the ESR is high, the patient should be investigated in those lines. And if infection is suspected, again, you have to look for the inflammatory markers. If they are high, then a limited MRI scan is recommended to know the site of lesion. If inflammatory disease is suspected, like history of severe early morning stiffness for more than half an hour, then routine FPCs, ESR, CRP, and HLA-B27 may be necessary. X-rays of the lumbar spine are very non-specific, and even in patients with ankylosing spondylitis, it is less sensitive to show sclerosis of the sacroiliac joint. I mean, MRI in such individuals might show whether the disease is active or not. Coming on to the spinal fracture, again, X-rays will show there is a fracture. It will not show whether the fracture is recent or old. It will not show whether there is edema or not. And if a vertebroplasty is being contemplated, they recommend that the patient has got an MRI scan to know whether it is a recent or old fracture. Again, MRI is helpful to identify an pathological fracture from an osteoaortic fracture. So I clearly said that increasing use of MRI scan is associated with the increasing interventions. So the patient might be put on to harm by over-investigating. So you want to know whether the pain is somatic pain or neuropathic pain. The most important clue is from the history itself. So if the patient is complains, if the pain is there all the time, it's much more suggestive of somatic pain as opposed to a nerve pain which is intermittent, and the patient usually describes it as a sudden shooting lancinating pain. Whereas for the somatic pain, it's much more like aching, like most often like a headache type symptoms. Location, it often gives a real clue. Like if it is a nerve pain, it will follow the distribution of the nerve, and when the patients are asked to show, they will use one finger to show that pain starts from here and goes all the way to the foot. However, when you describe the somatic pain meaning that the lumbar facet joint pain and the disc pain, it can also radiate to the leg, but it usually goes up to the knee. And the patients will usually use their whole hands and say their pain goes down like that, as opposed to a single finger. So the clue is in the history. And the nerve pain is more often present at night time. And obviously, on examination, we have to look for the sensory changes, motor changes, and reflex changes. And most of you would be familiar about the straight leg rising, but again, in a clinic, I think you got about 7 minutes for individual patient. You cannot examine the patient fully. So this is the slump test is recommended for patients. We can examine the patient sitting down itself. Hopefully it opens. It's a video I nicked from YouTube. Doesn't open. Okay. I can show it here actually. Can I have a volunteer please? Yeah, come on. Thank you. So let's sit down here please. That's fine. So if you do a straight leg rising test, you have to already ask the patient to lie down and then you lift the leg. Usually if they have a trapped nerve, they will have a shooting pain that goes down to the foot less than about 40 degrees. That's quite significant. But again, we can examine the patient sitting down as well. We have to ask them to slouch forward. So put the hand like that, and then we have to lift the legs slowly. So if it is a nerve pain, they will complain of shooting pain going down to the foot. And again, if you want a little bit more confirmation, we can flex the leg a little bit more. So if it is a trapped nerve pain, the pain will shoot down. If they will also have similar symptoms of hamstring pain. However, you can ask the patient to relax down. The hamstring pain will go away. Thank you. Thank you much. There we are. Video has played up. So there are several screening questionnaires which has been validated to help identify the nerve pain. The Leeds Neuropathic Assessment Scale and the Pain Addict questionnaires are some of them, and the advantage of this is these questionnaires are quite simple to fill in, and the patient can fill it in while they are waiting to see you in the clinic. He's got a series of questions, and a score of 19 and above indicates that pain is probably neuropathic. It's got a sensitivity of 85% and a specificity of 80%. Next one. On examination, that individual who came to clinic, he has got a severe shooting radicular pain. Okay, now we are going to discuss about the management of radiculopathy. It is important to exclude Aorta equina, and the first line of treatment would be to try some neuropathic drugs and to recommend physio and to educate the patients that they can rest for a few days, but again, in those days they used to rest the patients for a few months, and they used to use traction as well, but now it has been shown that that can cause more harm than help, so it's not recommended anymore. MRI is indicated if the pain is increasing and the nerve symptoms are increasing, and then the patient might be referred for image-guided intervention like an epidural or a nerve root block, or if the patient wants to go ahead down the surgical route, it is entirely appropriate to do so. The most common cause of radiculopathy is a slip disc. I think Nimbangat will speak to you about that in a minute. About 85, the reassuring thing is about 85% of the slip discs will improve by themselves in 6 weeks' time. So again, it is a cause for watch and wait really. And the most important thing is the patient should be educated about the signs and symptoms of Aorta equina, and if they have any, they have to rush to the accident and emergencies immediately. Most of the litigations, serious litigations, are from this, for missing Aorta equina. The essential criteria are dysfunction of bladder and bowel, and the patients will have saddle anesthesia and saddle analgesia. The other most commonly occurring symptoms are low back pain, with or without sciatica. It's important to note that with or without. So the patient might still present without any leg pain, but still have significant compression of the nerves. And they might have sensory changes in the lower limb, and they usually present with the lower limb weakness, and the symptoms can be unilateral as well. So you have to keep all these things in mind. And study, I mean, they should be operated as soon as possible, usually within a day or two. Some study shows that within 6 hours is ideal, but again, I don't think that's achievable. There's a randomized control study which showed that if the patients are operated within a day, about 87% of them recovered the nerve functions. However, if they are operated more than a day later, only 43% recovered the nerve symptoms. Okay. And it's stuck. So the initial management obviously is to encourage reactivation, educate that exercise is good for them, try to keep the muscles moving, try to stretch and relax the muscles. Thank you. And we have to address the patient's individual's concerns and expectations. They might worry that they might going to end up in a wheelchair. You have to explain them it is very, very, very unlikely. They can cause more harm by not moving than by moving. And the map of medicine also recommended online information. Go to the next slide. And again, it is important to identify the initial consultation, the risk factors of the low back pain becoming long-term an issue. And if the patient has got any of these yellow flags, they should be it should be addressed early on, or they should be referred for a CBT program either in the hospital or in the community. I think I'm aware of some places have got a mini CBT outside in the community. And the medications, it's for somatic pain and nerve pain. Somatic pain we often follow, we all know that we should follow the WHO ladder approach, starting with simple drugs and slightly increasing them to higher medications. I think some of you might have heard of about the tapentolol. It's a newer tramadol type weak opioid. It's not yet available in the hospital, but I'll be applying for the license soon. And strong opioids, although they help to reduce the symptoms, they cause more harm in the long run. So maybe a short course of strong-acting opioids is okay for someone with severe disabling symptoms. However, it's not ideal long-term. It's not an ideal solution long-term. Stuck again. So neuropathic pain, how to treat neuropathic pain. I'm sure most of you are aware of these NICE recommendations that was in 2010. The first line of treatment is either with amitriptyline or pregabalin, depending upon the individual risk factors. Amitriptyline is not ideal for someone more than 70 years of age because of its risk of atrial fibrillation and cognitive dysfunction. Second line treatment, if amitriptyline was used first, you try the pregabalin and vice versa. If they don't help, you can try a small dose of a mixture of amitriptyline as well as pregabalin. And the last line is consider tramadol or consider strong acting opiates, and consider referral to a specialty. So these are the difference between gabapentin and pregabalin. I mean, most of you would be thinking which one to use, gabapentin or pregabalin. The main differences are gabapentin acts in about 3 to 4 hours, whereas pregabalin acts very quick. Gabapentin takes about 3 to 4 days really for the patients to notice some improvement. However, pregabalin is a little bit more quick acting. And gabapentin is non-linear pharmacokinetics. It means that increasing the drug doesn't mean that the plasma concentration will be high, because of the absorption is not that reliable. So only 66% is absorbed, whereas pregabalin 90% is absorbed. And we know that gabapentin is cheap at low doses, but it can be expensive at higher doses. Like if you go more than, I think 1.8 grams a day, I think they are equal priced. And pregabalin has got an added advantage of improving sleep. They say that it improves the REM sleep, and it's an anti-anxiolytic. It is licensed for anxiolysis. NNT, I think most of you are familiar of NNT, is the number needed to treat. So to get one patient symptom free, that is 50% relief from the symptoms, you have to treat 5 patients. So that is the lowest you could get. Loxetine is recommended as first line for diabetic neuropathy, and you can see the NNT of gabapentin is equally good. However, pregabalin is good only at reasonably high doses, but many patients cannot take 600 milligrams because of the limiting side effects. Topical capsaicin, although the NNT is 11, but still it is cheaper, it is risk-free. I think it's still worth a try. So dose titration, these patients should be educated not to expect dramatic relief. So the drug should be started at a low dose and slowly increased. And I suggest a low dose for elderly patients. Amitriptyline, although it's recommended as the first line drug, those studies were done several years ago, and the numbers of the sample size was really small. So more research now is needed to know whether amitriptyline should be the first line drug when compared to the other line drugs. But because it's been used traditionally, it is still, we recommend it as the first line drug. Coming on to side effects, anticholinergic side effects are more common in the tricyclic antidepressant group. Dizziness is more common in the calcium channel blocker group, and almost all the drugs increase appetite. However, loxetine is one that reduces the appetite, and it is the one that causes more nausea. And it's important to let the patients know that these drugs can affect their sexual drive. So they are aware that it's not them, it's probably because of the drugs. And once they reduce the drugs, the sexual drive is going to come back. I'm going to rush off with one last slide. Antibiotics for low back pain. There is a recent publication that antibiotics can cure back pain. However, it's not true. The study is based on one trial. What they did was when they removed the slip disc from the operation, they grew the slip disc outside. They grew low-grade anaerobic bacteria that causes the acne. So they started treating with 100-day trial of Augmentin, and that one single trial showed significant improvement of low back pain with antibiotics. However, it was just based on one trial, and we should not be rushing on into treating patients with antibiotics. And this is the recommendation of the British Pain Society and the Royal College of Orthopedics. They both recommend that antibiotics should not be used routinely until further evidence is available. However, it will be very good. If it is because of an infection, at least we know that is a treatment for it. When H. pylori was said to cause ulcer several years ago, there was huge uproar. They said no way it's going to be true, but now we know it's true. So further trials are being done in that line to see whether it's because of an infection. Nearly finished. Thank you very much. Thank you.